Diagnosis. It is scarcely possible to mistake a fully developed intermittent hydronephrosis. The large, recurrent lumbar tumor is characteristic. A fixed hydronephrosis may be distinguished as a chronic, non-inflammatory renal tumor. When large, the cystic nature of the growth is obvious. It may then be mistaken for ovarian cyst. When small, it is not always possible to distinguish a hydronephrosis from other tumors of the kidney. The occurrence of hematuria may confuse the clinical picture. Accurate diagnosis is made by the ureter catheter. The urine obtained from the hydronephrotic kidney always shows some deficiency of urea and, unless the kidney is almost wholly destroyed, an increase in quantity as compared with its fellow, unless the condition is bilateral. The phenol sulfonaphthalene output is much more markedly interfered with than that of urea. If the ureter catheter can elude the ureteral obstruction and enter the kidney pelvis, the presence of hydronephrosis is immediately attested by a free flow of urine. This flow does not measure the capacity of the kidney pelvis, for this cavity may not be distended at the time of catheterization. But however empty it may be, there is always some residual urine present. To measure the capacity of the renal pelvis by filling it with fluid introduced through the ureter catheter is a dangerous experiment and has, after all, no value, for there is no advantage in knowing the precise size of the hydronephrosis. Moreover, a much more accurate picture is obtained by pyelography. Since ureteral peristalsis is lost above the ureteral obstruction, the situation of this may be estimated from the point at which the urine flows in a constant stream as though the end of the catheter were in the kidney pelvis. If the catheter will not pass the ureteral obstruction, even if no urine is obtained, pyelography is again our salvation. Thus, pyelography is the last resort for an accurate diagnosis. It should only be performed with the patient in the hospital, ready to be operated upon if occlusion of the ureter results. Through it, we may obtain not only a precise picture of the dilatation of the kidney pelvis and of its ureter, but also considerable information as to whether the ureteral obstruction is due to a kinking of that canal or an actual stricture. It is not to be forgotten that many of the smaller renal dilatations are actually not harmful to the patient so long as they drain freely into the ureter. A sharp angulation at the junction of the ureter and kidney pelvis and a convexity of the lower border of the kidney pelvis, the so-called derby hat pelvis, suggests that drainage is not perfect. It is further to be noted that the normal ureter, with the patient on his back, drops in practically a straight line from the kidney pelvis to the brim of the bony pelvis. The practice of taking pyelograms with the patient erect so as to bring out the kinking and convolution of the ureter has led to many mistakes in diagnosis, for the kinks and convolutions thus produced are not always pathological. Deductions should therefore be drawn only from pictures taken with the patient lying on his back. Prognosis. Unless both kidneys are affected, hydronephrosis does not threaten life. The development of the tumor is very slow, and treatment is usually demanded for the relief of pain. Infection may occur, transforming the hydronephrosis into an infected hydronephrosis, common, or into a pyonephrosis, rare. Rupture of the sac is most exceptional. Morris noted the spontaneous and permanent disappearance of 6 or 7 out of 47 hydronephroses observed by him.